Okay, I think we are going online now, and for the third live case, and of course, Professor Hankis will be coordinating, moderating, and sort of teaching us during this. You guys.
Okay. Really? Really? Yes. It's not loud enough. Now it's better. It's okay. Good. Good. Okay. How is the previous patient doing? The previous patient is perfect. Okay. Do you have a final angiogram? Yeah. Okay. So this is a final angiogram of the previous patient with a repositioned P-conus tool, which is now fully inside this land, fully inside the aneurysm, right? Okay. So what's going on now?
So now it's a 70 years old patient with accidental aneurysm.
Some 60-year-old man. He has a positive family for aneurysm ruptures and has an ACOM aneurysm, which was treated something like 10 days ago with a flow diverter from the left A1 to the left A2, and has another unruptured aneurysm on the right, MCA bifurcation aneurysm, which is supposed to be treated with another flow diverter. He had in his history, as far as I remember, he had a story of one of his family members with a surgery. So of course, we discussed and offered surgery, and there was any experience in the family, so he didn't like the idea and preferred endovascular treatment.
So
the patient is loaded with aspirin and prasugrel, or aspirin and ticagrelor?
Can we get the aneurysm picture?
Aspirin and ticagrelor, okay.
The aneurysm image.
Sorry?
Okay, now we can. And if 3D is there, that will be terrific. Somehow we can see the 3D.
Which is almost gone. Yeah, so there's a tiny remnant of the ACOM. It was much bigger. It is obviously obliterated within 10 days with the P64 treatment. You may see the remnant. It was a multilobulated aneurysm before, only filled from the left ICA. And you don't have any previous image, right, by any chance? I think we did it on the same machine. I think we did it on the same machine, right?
Yeah, you are right. We have it in this machine in the Mahouti.
So the previous treatment, treatment was done on the same system, and Dr. Almata will show us the image in a second. So now, 8 French or 6 French guide?
Das ist 7 French again, with intermediate catheter, because we prefer to go with everything from the beginning, just in case. But normally you just do that.
So Marta is saying usually what is absolutely true, usually we use no triaxial access. For this kind of procedure, usually a plain 6 French guide catheter is enough in order to make sure that the procedure goes smooth. She had a dual axis intermediate catheter with a 7 French guide catheter, and most probably a Navian or a in Neuroco. It is in Euro. Marta is saying it's in Neuroco. A Codman catheter. Okay. The pictures are deleted meanwhile. Okay. Anyways, so today, right MCA aneurysm. No, it's. Do you have it?
No. The old picture we have.
Okay.
I don't know why, but it's not in the machine.
Okay. So this is the injection of the right ICA, and this is a 2.65 millimeter distal branch, the superior branch, and the M1 has 274. So you will use a 2.5 or 3 millimeter implant.
A 3 millimeter.
A 3.
Because proximally is easier to deploy,
Yeah.
and it's more stable than 3 millimeter. And proximally is almost 3. So I expect it with the 2.5 by 9, a little bit shortening could be a little bit difficult to place. It's the reason because I would prefer to 3.
Okay. So the argument for 3 is that she expects a better. Her argument is that despite the fact that the 2.5 millimeter implant would go up to 275 physically, it could be just a little too small, too thin, and it's certainly better. I fully agree. It's certainly better to use a 3 millimeter device for this case.
Can I ask a question?
Yeah. Yeah.
Why do you want to treat a 2.6 millimeter incidental aneurysm in a 60 years old? What's the philosophy?
The philosophy is that the far majority of ruptured aneurysms we see are somewhere between 3 and 5 millimeters of diameter. So the patient has a substantial risk of rupture. He personally has 2 aneurysms, and he has 2 family members with rupture.
Okay.
Somehow in India also we are seeing overall them rupturing at a smaller size. We frequently treat 2 millimeter, 3 millimeter ruptured somehow, overall at small size. So what's the device being planned here?
It is a P64. Okay. We had been discussing P48 or P64. The argument for P64 is there are 2 arguments. The official CE mark for P48 is delaying for a variety of reasons, and we see that they are. These are not ideal conditions for flow diversion, right? We have this branch coming just adjacent to the origin of the inferior branch is adjacent to the aneurysm, which is a factor which is delaying the aneurysm obliteration, and we know from experience that P48 takes significantly longer to obliterate an aneurysm than P64. So with P64. We know that after 3 months, we do the first angiographic follow-up, usually within 3 months. We see about 80% complete aneurysm occlusion, and this is significantly lower with P48.
All right. And which is the microcatheter being used here?
The catheter is at XT27?
All right.
Yes, it's the microcatheter is a XT27 from Stryker. The wire is a Portal from Phenox. 14 wire.
And sizing, it has been decided about? What size P64?
It should be a 3 millimeter so the arguments for a 3 millimeter are several. So in the region we are dealing with, I'm distracting you, Marta. Should I take another cell? Okay. So the argument for 3 millimeter is that there we still may expect lateral lenticular stride branches, which we don't want to occlude. If we have there a little oversizing, we have less coverage. And another argument is that the interaction, the opposition of the 3 millimeter is expected to, with the target segment of the MCA, the interaction is probably better than with a 2.5, which may be a little too small proximally. It would certainly fit distally, but it may fall short proximally.
So we will show you the flash in the
Yeah. A difference between P64 and the other flow diverters is that you can remove the air entirely from the interstices of the flow diverter, but deploying it underwaters. So that's what they are doing now. They are deploying the flow diverter underwater.
So you do that in every case?
We do this in every case in order to avoid any
Okay.
micro air emboli.
Can they sort of zoom in there somehow? Can we look at this tent when it's deployed in water?
Wait a second, Marta. The zooming takes a second. Okay, good.
Yeah.
Okay. Now they will advance the flow diverter underwater. And if they are not shaking, there's always a bubble, a big bubble coming out. So the bubble is gone with the first.
So you deploy it partially and just withdraw it?
No, you can fully deploy it.
All right. Yeah.
And then you pull it back, and in this process you see a big bubble coming out the mesh. In addition, at this moment we usually give 500 milligram thiopental in order to securely avoid any inadvertent movement. And the anesthesiologists change the ventilation parameters to 100% oxygen, hoping that in case there is any air bubble in place, this would be counteracted by this high oxygen ventilation.
So this is very interesting, but do you give 100% oxygen in all your flow diverter cases?
Starting at this point.
All right, that's interesting. Mm.
Hans, do you think, these remote hemorrhages that we see now with flow diverters, do you think they are, you don't have a proof, do you believe that they are because of this air emboli?
I don't know it. I encountered maybe three or, as far as I remember, three remote parenchymal hemorrhages in case I have done by myself. So I would say I can nothing identify I did wrong. So there was no embolus, no air in the tubing system or something. So it has to be something we cannot predict. And incidentally, I reviewed a paper for neurosurgery which was ultimately published. It's from one of the authors is a German guy, Timo Krings, and they describe the usage of angioscopy under various conditions in vitro. And using angioscopy, they showed a real shower of air while deploying a pipeline. So this is just, it is a theory that's certainly far from any proof or something. It's just, yeah. And what I can say is, as far as I can know, we never observed a parenchymal hemorrhage.
All right, so can under fluoroscopy they shows the markers and you can point it out? Can we get so they can,
sure, I can.
Or they can take a single shot, whichever way. Yeah, now we can see it. Perfect.
So this is a wire.
Mike.
This is a wire which is in this case in P64 not movable. So it has a passive relation, a fixed relation to the insertion wire and the implant. So this is the tip of the wire. The catheter will be pulled back, and then Marta will gradually deploy the P64. You will see it in a second. So she will she will most likely start a little beyond the bifurcation with the deployment, so we know from experience that the foreshortening we expect will bring back the distal end of the implant, which is here. If you deploy here, you should end up here just at the bifurcation. I will now stop commenting and not to distract Marta for a second.
Yes, you can ask a question. Yeah, without the mic.
The P64 you get is, there are two types, aren't there? One with the distal wire and one without the distal wire. Am I correct?
The one with the wire is without the wire is no longer available. It's no longer manufactured.
Would you like to describe what's happening?
Yeah. So now what we now see is, I think under roadmap, we see now that the aneurysm is hopefully entirely covered. Martha will probably do a run to make sure that this is the distal end of the implant. She says it's maybe too short distally. Yeah. Yeah. So she's saying her feeling is that the distal end is a little too proximal, and the reason for that it is not is it really uncovered or is it just beyond? Uncovered, okay. Or it's at least at the border, and the reason for that is that she thinks that the microcatheter, the XT27, probably straightened a little the distal M1 segment, and with this straightening, there was a kind of a misalignment of the implant while deploying.
So I think it's just at the border, but I think it's too at the
Yeah.
I will try to put that in the
Yeah. She will.
this one is possible.
Yeah. She will try to replace it, if possible, a little more distally. Yeah. The roadmap is misleading due to the fact that the position of the whole thing has changed. Sir?
Next time when she deploys, can we have the fluoroscopic images above?
Yeah,
You know?
okay.
Yeah.
This is the second deployment. The
Already
second
happening.
deployment started more distally than with the first attempt.
Can you just point it out to the people?
And now that's the wire, that's the distal end of the implant, and you see the wire is moving. The wire has to move. If it's not moving, it is not wandering distally, something is wrong. So now there's a more distal deployment. Now it should be covered. So she's doing a run.
Yeah.
Yeah. So now we can say for sure we are distal to the aneurysm and proximal to the bifurcation. So perfect position for this purpose. And she will now detach the implant from the insertion wire. And the micro? Can I have the micro?
Yeah.
Wait, do you hear me? Do you hear me? Okay, good. So Marta will now detach the system. Maybe go with the camera on the table, right? Could we see it on the table, or one? Yeah. Okay. Okay. What you see here is a broken. No, it is. Here, it is not a. It is not a torquer. So this is just an instrument to fixate the relation between the detachment tube, this little plastic piece, and the wire. So don't try to use this as a torque device, it won't work. So she will remove this, put a regular torque device on the wire. When you remove this, you have to make sure that you don't torque the wire. There should be no torsional moment on the wire, otherwise you will prevent further detachment. So she's holding this piece and is closing the torque device, a reasonable distance between this plastic holder and the torque device is the real torque device is 2 fingers, and then she will hold the torquer and will move the tube towards the torque in that direction. Yes. So, okay, good. And can we, yeah, so we see here the movement of the detachment, and we will see the detachment hopefully on this fluoroscopic image in the right lower field.
Yeah, this is perfect.
Yeah, so now it opened. The complete opening of the device is visible by seeing these 8 proximal markers. And there is no need to go through the device once it's deployed. You can just gently pull back the wire. If you go through with a catheter without reason, you may invaginate the flow diverter. So it's better to stay there, to gently pull back the wire as it's done here. Yeah. So no interaction between the wire and the flow diverter. So, final run in apnea. So, no damage so far, right?
That looks good.
Okay, good, perfect, excellent. No. No. Whole head run. So very good. Thank you very much.
I think.
There's a question. Wait a moment.
Danke schön, ausgezeichnet.
Great. So I think you can convey all of us highly appreciate. I mean, it's not easy to do live transmissions and everything, and we highly appreciate well done cases.
Marta?
You know,
Marta?
I say India appreciates.
They think you were nervous. They don't know you.
Oh no. So
I don't think Martha cares.
yeah. Anyway, thanks a lot. That was terrific. I don't know whether she can she hear us? No. Can she hear us? Yeah. Yeah. Okay. I'm Vipul Gupta. Thanks a lot. All of us highly appreciate the cases done. Nice demonstration. Thanks from India. Thank you.
Thank